We'll get started with the lecture today. Again, I'm Dr. Stephanie Poon. I'm one of the orthopedic surgeons at Stanford and director of the Hip Preservation Program at Stanford Children's Health. Today, we'll be focusing on hip dysplasia and slipped capitofemoral epiphysis. First, we'll talk about developmental dysplasia of the hip. So the hip develops with the rest of the skeleton over the first 15 years of life. And normal development of the femoral head and the acetabulum is codependent, dependent on proper contact between the femoral head and the acetabulum or the hip socket. So without that proper contact, the acetabulum becomes very shallow and the femoral head becomes very misshapen. Dysplasia exists on the spectrum of the least dysplastic, which is where you have a stable hip, just a shallow acetabulum, to the most severe type of dysplasia where the hip is actually dislocated and the femoral head is out of the acetabulum. The severity of dysplasia determines when symptoms develop. So in patient A, this patient had a dislocated hip and presented early on in life with abnormal hip range of motion and an abnormal gait. Whereas in patient C and patient D, those patients did not develop any symptoms of hip pain until they were 20 and 27 years old because their hip dysplasia was more mild. The estimated incidence of hip dysplasia is about 1 in 1,000 newborns, but hip laxity in itself may be a little bit more common than that. It seems to be higher in at-risk infants, and we'll go over those risk factors very soon. It was historically higher in incidence in cultures that actually swaddled the legs tightly and straight together, such as in certain populations of Native Americans and Japanese. There are some genetic risk factors for developing hip dysplasia, and the strongest ones are being breech position in the 3rd trimester. Frank breech is at highest risk, and a positive family history is also a very strong risk factor for developing hip dysplasia. Females comprise 80% of hip dysplasia cases. There are some modifiable risk factors that do exist, including improper leg swaddling. So there are many benefits to swaddling newborns, but incorrectly swaddling the legs, where the legs are tight and straight together, putting the hips into extension and adduction actually aims the femoral head up and out of the acetabulum, preventing proper contact for proper development of the hip joint. The correct way to swaddle the lower extremities is to loosely swaddle so that the hips can be flexed and abducted into this natural frog type of position with room for the legs to move. Because flexion and abduction of the hip ends up aiming the femoral head into the acetabulum to allow for proper contact between those two elements of the hip joint. Baby wearing is also a modifiable risk factor. So a good way of wearing the baby for caregivers is to have the baby facing the parent or caregiver with the legs in this M sort of position where the hips are flexed and abducted. You want to have a baby carrier that has a very wide base that provides support for the thighs so that the legs are not hanging straight down. And we also want to avoid slings that put the legs in an adducted position. Hip dysplasia is the most common cause of hip osteoarthritis in young adults who develop osteoarthritis and need a hip replacement. And so it is important to diagnose hip dysplasia and to treat it. The outcomes of hip dysplasia are best when the hip growth and remodeling normalizes before 12 months of age. DDH is much harder to treat after a walking age. And we know that in incongruent hips, so a femoral head and an acetabulum that do not fit together well, by the age of 2 to 3 years, usually leads to poor hip anatomy in adulthood, and that leads to arthritis. So the goal is to identify and treat DDH before 6 months of age so that there is adequate time for remodeling before a year of age. So who receives a clinical exam? All infants should receive a clinical exam of their hips at every well child visit until they achieve a normal toddler's gait, usually around 2 years of age. On clinical exam, the Ortolani test is the test that determines if the hip is subluxated or dislocated. So what you feel is the clunk of entry of the femoral head into the acetabulum. So if you have a dislocated hip, if you flex the hip end, abduct the hip, and you elevate the greater trochanter, then you can usually feel a femoral head sliding into the acetabulum. This requires the infant to be quite relaxed during the exam. The Barlow test is the opposite. It's the clunk of exit of the femoral head from the acetabulum out of the socket. So this indicates instability or laxity of the hip, but not necessarily a dislocated hip. The hip is flexed and adducted, so the knees are brought together, and there's gentle posterior pressure applied at the knee to try to push the femoral head out the back of the acetabulum, and you will feel a little bit of sliding with a positive Barlow test. The Galeazzi sign is where if you have a dislocated hip and you flex both hips up to about 90 degrees and you flex the knees too, if you look, the knee that is on the same side as the dislocated hip will appear shorter than the normal contralateral knee. So in these pictures, both in the infant and in the toddler here, the left hip is dislocated. So you see the left knee is lower than the right knee. Limited abduction is the most reliable late diagnostic sign in infants who are 3 months old and older. So in this patient, you can see when the hips are flexed and abducted into this frog position, the right hip abducts more. So the knee comes down towards the table a bit more than the left hip, which is dislocated. And this is because with being dislocated for a longer period of time, you get some remodeling of the muscles and soft tissues. They contract around the dislocated hip, limiting the amount of abduction that you will find. There's some less reliable physical exam tests, such as thigh skin fold asymmetry between the two legs, or very soft hip click with range of motion of the hip. These don't always indicate hip dysplasia, but if there's any doubt, I always recommend just checking with some imaging. So speaking of imaging, who do we evaluate with an ultrasound? So infants who are 4 to 6 weeks of age to about 6 months old should get an ultrasound if they were breech presentation in the 3rd trimester, so breech position really, regardless of gender or delivery method. If they had a positive family history in a first order relative of DDH, a history of a previously unstable hip. So say on newborn exam in the hospital, someone felt a positive Ortolani or Barlow and it might have gone away on subsequent exams. I still think it's safest to check with an ultrasound. A history of improper swaddling of the legs being swaddled tightly together. A suspicious or inconclusive physical exam, or if there's parental concern, I think it's low risk to get an ultrasound, but potentially high yield. With ultrasonography, it really provides a real-time, objective, dynamic evaluation of the hip that is better than just physical exam. And so what we're looking for in an ultrasound is an alpha angle of greater than 60 degrees by 4 to 6 weeks of age. And we should also see greater than 50% femoral head coverage. So in this image, this angle here, drawn in yellow, is the alpha angle. And the bigger that angle, the more normal the hip. And the femoral head coverage is determined by how much femoral head is below this horizontal red line covered by the roof of the acetabulum. Ultrasound is reliable until about 5 to 6 months of age, at which point the ossific nucleus or the growth center of the femoral head starts appearing and the ultrasound becomes less reliable. So usually at that age, we transition to radiographs or x-rays. If you get x-rays too early, then the ossific nuclei have not appeared and can give a false impression of hip dysplasia. So I wouldn't necessarily get x-rays younger than 4 to 6 months of age, but usually by 6 months, we switch to x-rays. And the signs of DDH on an x-ray include an absent ossific nucleus, where in this picture, you can see there's an ossific nucleus on the right side, this little dot, whereas on the left side, you see no dot, no ossific nucleus. Or you can see some asymmetry in the ossific nuclei side to side. So one looks a lot bigger than the other side. You may see an increased acetabular index, which is an angle that quantifies the slope of the roof of the acetabulum. And Shenton's line may be disrupted. Shenton's line is an arc that is drawn from the top of the obturator foramen here over towards the inferior aspect of the femoral neck. And if that arc is disrupted, that can indicate a subluxated or dislocated hip. When to refer to peds ortho, if you find a dislocated hip, so a positive Ortolani on exam at any age, you should immediately refer. If you find an abnormal ultrasound for an infant who is at least 4 to 6 weeks old, or an abnormal x-ray for an infant who is 5 to 6 months old or older. The general treatment guidelines for hip dysplasia are less invasive the younger the infant and more invasive the older the patient. So from birth to 6 months, usually a Pavlik harness for bracing is used, seen in this picture up here, this happy baby wearing the Pavlik harness. With an older infant or a younger child, sometimes a different type of brace or sometimes surgery is necessary with placement of a spica body cast in this picture. As children get older, it's more likely that more invasive surgeries are needed, including an open reduction, pelvic or femoral osteotomies. And in adolescents and adults who may still have hip dysplasia, then there are different surgeries, including a periacetabular osteotomy or a PAO, or even a hip replacement if there is arthritis. So I just wanted to touch on the Pavlik harness a little bit because I know a lot of our audience are pediatricians who see a lot of infants and may refer for infantile DDH. So my Pavlik treatment protocol consists of the indications for treatment, including a diagnosis of DDH confirmed on ultrasound at 6 weeks of age, and an Ortolani positive hip on clinical exam. The treatment duration generally is in 6-week intervals. So usually by 6 weeks or 12 weeks of full-time bracing, 22 to 24 hours per day, that should be sufficient for correcting the alpha angle and femoral head coverage. We check on ultrasound at 6 weeks and at 12 weeks again to check these parameters for normalization. And then once the ultrasound parameters are normalized, then we wean the harness for a period of 6 weeks where the infant just wears the harness at night and during naps about 12 hours a day. The usage of a Pavlik harness differs depending on if the hip is reduced and stable or if you have an unstable hip that is dislocated. So for hips that are reduced, usually we use the Pavlik harness for about 22 hours a day, and we let the parents take off the Pavlik for bath time and for tummy time a couple of hours a day. We follow up every 2 to 3 weeks for harness adjustments because infants in this age range are growing very rapidly. And we want to make sure that the pelvic harness is holding the hips in the right position. And we get ultrasound with stress views of the hip. So we try to subluxate the hip on the ultrasound to see how stable it is after 6 weeks of treatment. For dislocated hips, we follow a little bit more closely because there is the concern that the pelvic harness could be holding the hip in the wrong position, or if the femoral head dislocates while in the harness, we want to catch that early and correct that. So initially, the pelvic harness is kept on 24/7, and parents just kind of sponge bathe the infant around the harness. And we keep it on 24/7 until the hip is clinically stable and confirmed on ultrasound to be in the right position, reduced. We follow up every week with a clinical exam and adjust the harness. And at 1 to 2 weeks of pelvic harness treatment, we get an ultrasound in the harness to confirm that the femoral head is reduced. And then at that point, we can let the infant take off the harness for a couple hours a day once we know that the hip is reduced and stable. And then we also get an ultrasound at 6 weeks of treatment to confirm what type of progress we've made. Typically, dislocated hips need a little bit more time in the harness than reduced hips to fully normalize. If there is residual dysplasia or adolescent onset hip dysplasia, the milder type that may not present until adolescence or young adulthood, then there's a different type of surgery called a periacetabular osteotomy, or PAO, that is able to reorient the weight-bearing surface of the acetabulum into a more horizontal and stable position to normalize the weight-bearing load across a larger surface area and to decrease the amount of stress on the cartilage to try to prevent arthritis. So this is an example of one of my young adult patients who had a normal left hip, but a subluxated right hip with severe dysplasia. And this is after the PAO surgery. And you can see that these are screws holding the acetabulum in this new position. And now there's proper coverage of the right femoral head. So in summary, hip dysplasia is the most common abnormality in newborn infants, and there are both genetic and environmental risk factors that are associated with DDH, including breech position in the 3rd trimester, a positive family history, being a female, and having improper swaddling early on in life. The modifiable risk factors including proper swaddling technique and healthy hip wearing for caregivers. So prevention of DDH includes educating parents and all newborn team members on these modifiable risk factors. Earlier diagnosis leads to less invasive treatment and generally better outcomes in adulthood. So now we will move on to slipped capital femoral epiphysis, or SCFE. So SCFE is actually the most common hip disorder in adolescents 10 to 16 years of age. It tends to affect boys more commonly than girls. The incidence is about 1 in 10,000 adolescents. And what happens is basically a fracture through the proximal femoral physis, and the epiphysis, the top of the femur, displaces into a position of extension and retroversion. So the femoral neck becomes very prominent. You can either have a stable SCFE or an unstable SCFE. And the reason I mention this is because it is related to the risk of developing avascular necrosis, or AVN, of the hip. With a stable SCFE, there is a more chronic or slow rotation of the epiphysis, and this allows for remodeling of the lateral epiphyseal vessels, which supply blood to the femoral head. With an unstable SCFE, there is a more rapid disengagement of the epiphysis and acute displacement, which may result in compromise or kinking off of the epiphyseal vessels, disrupting blood flow to the femoral head. And therefore, with stable SCFEs, the incidence of AVN is really quite low, pretty much 0. Whereas with an unstable SCFE, up to 24% of these unstable SCFEs can develop AVN. The presentation of a patient with a SCFE is usually a history of antecedent knee or thigh pain for many weeks, with or without an inciting event or injury. Usually the patient will present with pain with weight bearing on the affected leg, and usually they will have the affected leg externally rotated. So they'll look like they're out-toeing when they're walking or standing, or even when they're lying down. So in the picture shown here of the feet, you can see that the left foot is externally rotated relative to the right. On physical exam, when you flex the hip, there will be obligate external rotation of the hip. So meaning the hip will want to externally rotate as you flex the hip, and there will be no internal rotation of the affected hip. SCFEs can be associated with endocrinopathies, particularly in the atypical patient. So the typical SCFE is where you have an obese adolescent. The atypical one is where you have a skinny adolescent and sometimes a younger child, so less than 10 years of age. If you have these atypical presentations, then it would be an indication to check for an endocrinopathy, most commonly hypothyroidism. The tests that you would want to look for is TSH, free T4, getting a complete metabolic panel, and also check for growth hormone and vitamin D. You do want to get imaging for a SCFE. And so the first x-ray that you would get is an AP pelvis x-ray, and you may see some widening of the physis, the growth plate, and some relative loss of height of the epiphysis. You may see Klein's line, which is a line drawn up the femoral neck here. You'll see that it will not touch the epiphysis or the femoral head because of displacement of the epiphysis. On the frog lateral of the hip, you may see posterior displacement of the epiphysis. And there's a way to grade the severity of the SCFE by measuring something called the Southwick angle. I won't go into the details of measurements, but in general, you can have mild, moderate, and severe SCFEs depending on how high the Southwick angle is. So treatment of a SCFE is surgical. So it requires urgent surgical treatment, and in situ fixation is the gold standard because it is very low risk and minimally invasive. Open reduction may be indicated in more severe deformities. The goals of surgery are primarily to arrest further progression of the deformity and to gain closure of the physis. The secondary goal is to minimize the deformity, especially with severe deformities or severe slips. The benefit of in situ pinning is that it is very small risk of AVN and minimally invasive, but the main drawback is that it does not correct the primary deformity. And so these patients may require further surgery to address residual deformity. But for mild slips, it may be better to have some residual deformity than to have a higher risk of AVN with more invasive surgery. With open reduction, the benefit is that you can correct the primary deformity and have better hip function. But the main drawback is that these require larger approaches, larger surgeries, and higher risk of AVN. So for severe slips, you have to weigh the benefit of correcting a severe deformity if it is just unacceptable, and it may be worth the higher risk. So speaking of residual deformity, it can lead to a condition called femoral acetabular impingement, or FAI, after the SCFE heals. And so this prominence of the femoral neck that you see with a SCFE, this is a patient who was pinned in situ, and you can see as the SCFE healed, there was some remodeling, but this prominence of the femoral neck persisted and developed into what we call a cam deformity, which can cause impingement against the rim of the acetabulum in positions of hip flexion. So this patient was treated with a hip arthroscopy to shave down that bump of bone to alleviate the impingement. But you can see in this arthroscopic video, this is the labrum over here, the cartilage ring at the edge of the socket, and this is the cam deformity. So you can see how when the patient would flex up the hip, that extra bone, the cam deformity, would pinch the labrum and scrape the cartilage, causing damage to the joint and increasing the risk of developing arthritis at an early age. So with mild residual deformities, arthroscopic femoral osteochondroplasty may be an option. So this is someone who had some mild deformity here, and this is a burr that we use to shave down the bone. So after the osteochondroplasty, you can see there's a more normal contour to the neck of the femur. For more severe residual deformities with this severe SCFE, sometimes femoral osteotomies are necessary, but these are much larger surgeries. So in summary, for SCFEs, the typical presentation is an obese adolescent with hip, thigh, or knee pain. If you evaluate the knee for knee pain and the knee exam appears normal or the knee imaging appears normal, then please evaluate the hip to see if maybe the pain is referred pain from the hip. Once you diagnose a SCFE, you have to treat it like a fracture. So place the patient on crutches with limited weight bearing and urgently refer them to orthopedics within the next day or send them to the emergency room. It requires urgent surgical treatment to avoid AVN and worsening of the deformity. And possible sequelae after SCFE include avascular necrosis and possible joint degeneration from residual deformity. So if you have a patient who had a SCFE earlier in life, if they have hip pain, then that would also be a reason to refer to orthopedics for further evaluation for these possible sequelae. So thank you for listening. I'll take any questions.
All right, thank you, Dr. Poon. That was excellent. So we have a couple questions in the Q&A. If you guys have any more questions, feel free to type them in as we go along. So the first question is, should ultrasound be obtained if physical exam is reassuring and there is only one risk factor present?
That's a great question. I think if there's any doubt, it's always safest to get an ultrasound. Especially if the one risk factor that's present is one of the strongest risk factors, such as breech position in the third trimester or a positive family history of hip dysplasia. But I think, ultrasound, there are some countries that have universal DDH screening, so they ultrasound every infant. And ultrasound is very low risk. So I think if there's any doubt, if there's any risk factor present, I would get an ultrasound.
Okay. Is diagnostic ultrasound different than therapeutic ultrasound? Therapeutic ultrasound is contraindicated on growth plates.
Yeah, I'm not a radiologist, but I believe that the ultrasounds that we do for infant hips are diagnostic ultrasounds. And so they should be very safe for the growth plates that we see in infant hips.
Okay. There's a couple questions from this one participant. It's about spica casts. If you could explain a little bit more about the technique or the material that you utilize to create the spica cast.
Yeah, so a spica cast is a body cast that immobilizes the hips in a position that is good for proper development of the hip. So we talked about how flexion and abduction of the hips. So, flexing up the hip or bending the hip and then spreading the knees apart or abducting the hips aims the femoral head deeper into the acetabulum so that there's proper contact between those two parts of the joints. And so sometimes bracing isn't rigid enough to hold the hip stably in that position. And so in those situations, a spica cast is a more rigid solution where you can really customize the position of the hip, and the patient cannot, or parents cannot, take off the spica cast. And so it is a technique that's very old, actually, but works very well for keeping dislocated hips in the right position, or hips that have not responded to bracing in the right position. There are a couple of different materials that you can use for a spica cast. Traditionally, it would be plaster and cotton. Nowadays, we use fiberglass, which is a bit lighter than plaster. And we still sometimes use cotton as a lining to pad the cast. But I actually prefer a different material that is Gore-Tex, and it's a Gore-Tex padding that is waterproof, which makes it a little bit easier for in case the spica cast gets really sweaty, especially in the summertime, or if the infant has a blowout or urine leaks into the cast. It's a little easier to dry out and to clean up.
Okay. Mm-hmm. And then from the same person, how is hip dysplasia clinically manifested in an adolescent? And then are there any delays in the long-term development of those children?
Yeah, so to answer the first question, for adolescent onset hip dysplasia, the typical presentation is an adolescent who probably had normal hips through early childhood, and then with higher level activities like sports or being more active, they start developing anterior hip or groin pain, sometimes lateral hip pain with fatigue of the muscles around the hip. But they start developing some discomfort, actually. And what we think happens is because the hip develops until early adolescence, there are certain growth plates that really don't quite turn into bone until late childhood, early adolescence. And it may be improper growth of these later growth centers that allow the acetabulum to be a little dysplastic and be insufficient in adolescence. And it also takes a little bit more time for milder dysplasia to actually create enough irritation of the joint or damage to the joint to actually create symptoms. So these patients usually present with pain, difficulty with sports, and usually they're diagnosed with x-rays. The second question, are there any delay in the long-term development of these children? I assume we're talking about the younger children who are braced or casted. So we actually did a study here at Stanford looking at whether pelvic harness treatment resulted in long-term developmental, motor delays in these children. And what we found were some of the earlier milestones, such as sitting, potentially even crawling, were a little bit delayed. But when it came time to standing and walking, those later motor milestones were not delayed. So what we think happens is while they're being braced, it's harder to move around. And so the earlier milestones are harder to achieve. But once bracing stops, then children will rapidly catch up.
Okay. Excuse me. Long-term follow-up after correction of FAI, is there a good prognosis?
Yeah, so we do not have long-term follow-up after correction of FAI resulting from SCFE. It does not seem that correcting the FAI that results from SCFE necessarily decreases the risk of getting arthritis later on in life. We just don't have that evidence yet. But the shorter term evidence shows that patients do experience a decrease or reduction in pain and an increase or improvement of hip range of motion and function by correcting the FAI that you see after SCFE. So you can at least provide patients with a higher quality of life and less pain, at least in the short to moderate term. But I think the long-term follow-up still remains to be seen.
Okay. Do babies with asymmetric thigh folds need ultrasound with the rest of the exam being normal?
Yeah, that's a tough question. I think if there's any doubt, so if you have asymmetric thigh folds and there's some doubts, there's maybe one risk factor, it's sort of a gray zone, but I think if you're suspicious, the safest thing to do is to get an ultrasound. The worst thing is that, get an ultrasound that's not needed, but at least you'll know. And the potential benefit of, catching a case of hip dysplasia early is just so high that, that I think, if there's any doubt, just get an ultrasound.
Okay. Once referred to orthopedics as a new patient, how soon should they be seen for this new patient visit for both DDH or SCFE? Within a week of new referral?
Yeah, so for DDH, it's a little bit less urgent than a SCFE. So for a SCFE, it's like a fracture. So you want to send that patient from your clinic to the emergency room or get them into an orthopedic clinic either that same day or the next day. For DDH, we do want to see them soon, but you could get them in within a week or two. We try to see DDH babies within a week. But it's not like a fracture. So a SCFE is certainly much more urgent.
All right. Looks like that was all of the questions.